Good morning, good afternoon, good evening, at whichever time of the day you might be taking on and ingesting this CUNY BMI dialogue. This is the first of many, we hope this year is the first of the 2025 year, and we are starting off with an absolute, as the kids would say, banger. We have not one, not two, but three doctors in the house who are here to educate us, who are here to just give us all the insight possible into what the state of health, mental health, physical health of the Black diaspora as a whole. And for that, we have our true and through number one host, Dr. Jeff Gardier, who will lead us through this great conversation with Dr. Maurice Selby and Dr. Rob Gore. Dr. Gardier, please take it away.
All right. Thank you so much, Jorge. A great attorney he is, and a wonderful addition to CUNY BMI. Hello, everyone. Good day to all of you. We have a very, very important discussion that we'll be sharing with all of you today, an exciting discussion where we're talking about the critical challenges endangering the psychological, the physical health, the mental health, and wellness, and really about the survival of our Black and Latino students and individuals in the community. And we are really blessed to have two experts who are in the trenches and doing this work. Let me first introduce you to someone that you know very well. His name is Dr. Robert Gore, MD. Dr. Gore is an attending physician, emergency medicine specialist over at Kings County Hospital in the great Brooklyn, New York. Dr. Gore, thank you really so much for being here with us.
Oh, Dr. Gardia, thanks for having me today.
All right. And also joining us, I think for those of you who are much older, there was a television show called Dr. Marcus Welby, MD. Well, we have the new and improved version, the version that is part of being a man of our times, and that is Dr. Maurice Selby, MD. And Maurice Selby, Dr. Selby, is an assistant professor and a director over at Emory for a program called Muse. That's an acronym for mentoring underrepresented students in emergency medicine, and part again of Emory University School of Medicine. And I thank you so very much, Dr. Selby, for joining us.
Thank you, Dr. Gardier, for having me. My absolute pleasure to join you all. And as a member of BMI, when sort of we kicked this off in CUNY, 20 years ago, almost 20 years ago now. It is crazy to be here today with you all. So really excited. I feel like coming full circle. So thank you. Thank you all for having me.
Absolutely.
Maurice, you're getting older.
I know, right? For over, to say the least.
And I understand, Dr. Gore. Is it true? I heard there's a rumor in the community. Dr. Selby is one of your proteges.
Yeah, I don't want to say proteges. He's one of my people, and we've known each other for a long time. He did participate in a program that I started a number of years ago, very similar to the one that he's running right now. But I feel like he's like the next extension of the work, and he's just another member of the community carrying on this work. But it's funny that we're having this conversation, like all three of us together. You know, we both of us have watched you, Dr. Gardere, on TV, and you know, you and I, we've got a chance to talk in person. Maurice and I have been having very similar conversations like this since 2011. So this is no different. Even in this format, he and I were together. I got to give you a little bit of background story. I don't want to just blow him up. Maurice is a phenomenal physician, dad, educator, mentor, and activist, and friend. But he's also was my roommate. He was my roommate during the pandemic because our wives were expecting, and we both got put out of the house. And so we actually were roommates for, what was it, 12 weeks?
It was like 12. Yeah, it was 11, 12, or 12
weeks. We were
weeks.
put out of the house, put out of our respective houses. Our wives are pregnant. Nobody understood really anything much about COVID. And we were sitting there grinding, working on a lot of these ideas about health, wellness, community engagement, and how to project and how to pass on these ideas of cultivating community wellness on larger scale. So this is just a continuation of many conversations in person and virtual. So, we're really fortunate to be able to do this stuff. And
Facts.
now he's out of New York City, so he's spreading the wealth even in other parts of the country.
That's right. He ran down south to escape the snow, and guess what? He's
Ran
stuck.
right back into it.
Ran back right into it.
And we
It
have
found me.
and we have no snow up east. But as we talk about
Heat
this,
wave, 35 degrees.
yeah, yeah, and it's getting warmer. And as we talk about this, of course, at the time that we are recording this, there has been really a catastrophe on the West Coast in the Los Angeles area. These wildfires that have caused so much damage and horror and death and displacement. So our prayers go out and our well wishes to all of the folks over on the West Coast. And for those of you who have family and friends there, so our prayers to all of you. Dr. Gore, it is not an accident, of course, that we have both of you as emergency room physicians, emergency medicine being your specialty. You actually wrote a book called Treating Violence. An emergency room doctor takes on a deadly American epidemic. And that's what we're talking about here, right? This American epidemic of mental illness, physical illness, accidents, gang activity, crime, all of the things that disproportionately affect us as far as being victims. Tell us a little bit about why you wrote that book, what the focus is, and how it relates to the idea that we have to somehow not address, but really try to save our Black and Latino males from a lot of the horrors and dangers that they're facing in their own right.
So the book itself, Treating Violence, it's about violence and conflict and how it affects our community. But it's really kind of a part of the story of what it means to engage with and take care of people who are in very vulnerable states. You spoke about the wildfires in California that are going on. We understand what took place during the COVID pandemic. Violence itself is not that much different in the sense that those people who have resources and safety nets tend to do a lot better health wise. Within our communities, we don't always have those same sets of safety nets. Our social determinants of health are definitely off balance. And because of that, things that are related to violence and trauma tend to impact us a whole lot more. But homicide itself is number one killer of black men ages 15 to 34. And I wish that number had shifted, but it hasn't. If you just look at across the United States, not even just including looking at black men, you've got close to, what is it, like 130? No, sorry, it's about 100, close to 180,000 homicides amongst young people ages 15 and 29. For every time you have a non-fatal injury, you have at least two to three. Every time you have a fatal injury, you have almost like two to three non-fatal. You've got, if you look at like FBI data in terms of violent crimes that are reported, you've got over 1.2 million reported violent crimes every year in the United States. And so I would say that that's a major problem. And we're not talking about people experiencing discomfort, a little bit of discomfort. We're talking about people who may lose their lives at the hand of someone else because either they were trying to take some sort of power, they were trying to get some sort of object, or they were completely dysregulated to the point that they didn't understand how to manage their own emotions and decided I need to take somebody out because they've caused me either mental harm or physical harm. So this is a major issue that's affecting people within our communities, and it's something that we've had to do something about, but looking at it through a very different and more public health lens that allows us to understand risk factors and then engage with those risk factors and see how do we come up with something to make sure that people not just stay alive, but put themselves in positions to thrive.
And Dr. Selby, what does that look like on a typical day in the emergency room? And we're talking about your being down south, of course, in the
Hmm.
area. What does that look like, and how do physicians experience what's going on with this constant stream of people
Hmm.
who may hopefully look like themselves? I would hope that there is a larger percentage of doctors of color working, I hope. But what does that look like in the emergency room?
So going back to what Dr. Gore just mentioned, as far as the one key word I want to focus on is vulnerability. Vulnerability. And the other word that I think we need to talk about is survival. And when we talk about vulnerability, it is on clear display. You could, our trauma center at Grady, as Dr. Gore pointed out, right, the majority of victims interpersonal violence, especially when we talk about gun violence, they are Black men. And it is a good subset of Black women, right, that are victimized in this way. And the thing that you'll notice, contrary to what we're sort of sold or what is popularized in the mainstream media, right, as far as Black men, aggression, the quote unquote thug mentality, whatever you want to call it, however you want to portray that, that is the total opposite of what you will see in the emergency department. You will see people vulnerable phase or their most vulnerable position, and I'm point of being right afraid of being having an IV placed, right? What's going on? What are you guys doing to me? It is not uncommon for us to have to perform digital rectal examinations, right? Looking for injuries related to bullet wounds, and these folks are freaking out. What are you doing? What's going on? You know, anytime you come near them, they're nervous. And that is something that, right, that is not just at that point in time as far as the injury, that is leading up to it, right? What is happening in their communities, as far as the divestment in those communities, the lack of social supports, as Dr. Gore was saying, the basics, right? We're talking about having a place to live, a safe place to go and sleep, having food to eat, having opportunities, right, that will not put you in harm's way. It is the very, very basics that are sort of left out, and individuals are left to, again, word I wanted to focus on was survival, right? Individuals are for themselves, and hence, right, when we talk about survival instincts, that is where another keyword, right, desperation leads individuals into situations, circumstances that can increase the chances of violent injury. Everything from interpersonal violence, right, defending your territory or your name in the streets, right, respect and having to fight for that. I think another author that sort of put this in, I think, very, very concrete terms was Ta-Nehisi Coates, Between the World and Me. He actually, I think, illustrated that very, very well, as far as why, right, that has to be sort of the facade, if you will, right, for a Black male in this country. We have to sort of put on, I don't want to call it a front, because I think we do have, sort of there's a strength, right, that is present that allows one to sort of deal with these challenges day in, day out. But it is vulnerability. That is the thing that really, really leads individuals to, sort of be in these positions where they're at increased risk for violence and end up in harm's way.
And one of the things, Rob, you're on mute there. You wanted to make a point, and then I'll go to my question to you.
Oh no, just in terms of like what happens with the stress response itself. So when when we are protected, when we are functioning in a very optimal state, we have the things that are essential for us to be able to survive. Dr. Selby mentioned, simple things like housing. When you don't have housing, when you don't know where you're going to sleep, when you don't know where your next meal is going to come from, you are easily going into that survival mode state. And on a physiologic level, when we're in survival mode state, we've got a cortisol response that gets triggered, and that's that whole fight or flight syndrome, which is supposed to keep us free and alive and be able to escape some sort of imminent danger. But when a lot of the issues that we wind up seeing with many of our patients who are coming in injured, they've already had prior stress responses. They're continuously undergoing a stress response, and there hasn't been any sort of period of respite. And so when that happens, little things like somebody looked at me funny, somebody stepped on my shoe, somebody just put their hand on my hand to ask me if I wanted something. Just kind of thinking, basic Southern hospitality. I used to live in Atlanta. People put their hands on you. There's touch, but something like that could be very, very triggering to the point that somebody who's on the receiving end and has been stressed out, and they've already had a pre-existing stress response to the point that is considered to be PTSD because they're experiencing these same symptoms from this one triggering event, and then you bring on another triggering event, that person almost implodes. And they can experience these periods of dysregulation where they really don't have much control over their emotions. And we've all been in spaces where people have said, "Oh, I just blacked out and I didn't understand what was going on. I don't remember what I said." But we don't realize the kind of stress that people are under. And part of the work itself, as far as just treating violence and creating spaces that can help cultivate wellness, is understanding what does it mean to be trauma informed. How do we have an environment that we know is both safe to make sure that people are free from harm, as well as brave, so that people have an ability to discuss the thoughts and the feelings and be comfortable enough and open enough to express emotions so that they can allow themselves to be vulnerable. That's where a lot of the healing tends to occur. And this is for any medical issue. If somebody can't have a simple conversation because they're so dysregulated, how is Dr. Selby going to talk to them about why it's important for them to take their asthma medication or their blood pressure medication, or to get them to go to the operating room because they have an infection in their gallbladder or in their appendix? It's
Or to
all
see their primary doctor, right? The
see a
basics of things.
primary doctor, or come back just for regular follow-up. These are things that are happening over and over, and you as a mental health practitioner, for a number of years, and well respected, we're now, I think, us in the regular medicine space are now coming to understand things that you have been talking about for decades. And so that's part of the conversation that I think needs to happen.
And
That bridge.
yeah, and the other part of the conversation, and you and I, Dr. Gore, had this conversation when we were walking to the train from one of the CUNY BMI dialogues, was this slow suicide, Dr. Selby, that we see that many young Latino and Black males, they don't have the anchors that you talked about, right? The education, roof over their heads, productive relationships, a job, education, and so on. And so they engage in behaviors, or are at risk for behaviors in which they end up in harm's way. How
Yes.
do you see that playing out in some of their behaviors once they enter the emergency room?
Hmm. Well, as far as one of the words that I want to pull back on a little bit is sort of this right, kind of like slow suicide. It's more like, from the societal standpoint, a slow homicide, right? Because again, going back to sort of the survival aspect of this, when we really dig down and talk to patients about their experiences in the emergency department, let's say after a violent injury, or they're there for another reason, they have the same motivations that we all have, right? They want to come out of that, for one, feeling better, right? Having maybe a diagnosis, a treatment plan. They want to recover, right? Many times they don't even want to in the first place. Whatever happened, they were trying to, just as much as we're all motivated to not be, in somebody's emergency department injured, or, having a medical emergency. They want to be in the same position as everybody else in this country, when it comes to living a happy, right, productive life.
Well,
But when we start off, yes, I'm sorry.
and Dr. Selby, and I guess what
Hmm.
I'm talking about is, when I use that term slow suicide, and I agree with you, it's a slow homicide too, right? Acting
Hmm.
out against others, again, being at risk for that. But, it's part of what we discussed earlier, this dysregulation of emotions. And so, they're in a position where they may not care about themselves or feel
Hmm.
powerless even more, and end up in these horrific situations, no fault of their own for the most part.
Hmm.
But how do you, and I'll address this with both of you, when that person comes into the emergency room, how do you get them to that point of now caring more about themselves, this being not just a medical intervention, but also a social, psychological intervention to begin
Yes.
not only get better, but to have perhaps more hope in their lives?
I think a lot of it starts with that interaction. from provider, right, to patient. Being willing to listen is probably the most important thing, because in that instant, right, where they realize that, hey, oh, wait, you're actually listening to what I'm talking about. You did not sort of label me, right, as um, a perpetrator of violence,
Right.
and or in being a victim of violence. Yeah,
Just some gangbanger
exactly.
shot up or whatever. Right.
Correct. Correct. That is where I think a lot of times we're able to really, in my practice, definitely able to understand that, hey, there is, right, when we talk about um, individuals and their sort of motivations for life in general, right? We're able to dig down, hey, there are some gaps here, things that were not addressed. That is why that patient is engaging in quote unquote risky activities, right? If you don't have a primary care to go to, and talking about the stress responses, and we can even talk about things like John Henryism, right? And sort of this constant fight or flight syndrome that you're in. How do you manage that, right? If you don't have a primary care physician or a mental health professional that you can go to get anxiolytic medications, right? Like benzodiazepines, things that can help you manage your anxiety or your responses to all of these psychosocial stressors, right? What do you turn to? Well, let's say things like marijuana, other maybe illicit substances, right? Depending on where you are in the country, alcohol. We just saw uh, Dr. Vivek Murthy, right, and sort of his Surgeon General advisory, talking about alcohol increased cancer risk. But when we talk about the things that are available to people to help deal with some of these challenges, right? Well, alcohol is there despite the risks, hypertension, liver disease, all of these things, right? That's what's available. That is what people are going to turn to in order to try to deal with these situations that they're dealing with.
Right.
Yes.
And the issue is in some of our African American and Latino communities, even the quality of the alcohol is much, much more inferior. And I'm not a physician, but my understanding is that can cause liver damage even quicker than, a higher grade or, more expensive type of alcohol. But we know all of these alcohol things, and
They can be
Dr. Gore
problematic.
tell us, these things are toxic.
But one more,
Yeah,
you
go
give
ahead.
people an alternative, right? And let's say, hey, I have a place where you can go, right? And we can talk about these issues. We have other ways of helping you manage your anxiety, prescribed medications that can even have to be controlled substances necessarily, right? Things that can just help people sleep, get a night's sleep, and rest, a good night. When you offer people, in many cases, you listen to what they're dealing with, and offer them alternatives, right? Not only you listened, but you offered an avenue for them to treat these things or deal with some of these challenges. They take you up on it, right? It's like, oh, I didn't even know you had a clinic that I can go. I didn't have insurance, that's why I never came here. But I did not know that we had certain charity programs available, or fee scales that'll make things affordable. And I see people showing up to the clinic. I'll check their chart and see that, oh yeah, they did follow up. Wow.
Yeah.
And even I'm surprised, right? Because this is something that can be in our minds as providers as well, as, oh, they're not going to follow up, right? Why should I spend my time or
Dr.
resources there?
Gore, and Dr. Gore, let me ask you about that, because I know you've made a commitment to specific early intervention in for treatment of trauma for those living in those impoverished neighborhoods, and in much of the environments that people of color, Latino people, and so on are disproportionately affected. Can you talk about that? Can you expand that from what Dr. Selby is saying? Yes, there is a haven, there is help for you, but how do we even do some of that prevention work for our Black and Latino males?
I think that's an excellent question. What can actually be done? It's almost there are like a couple of steps that I go through in my head anytime I go see a patient. The first is that as a clinician, as a healthcare provider, we have to recognize that we are educators. First and foremost, the body is going to heal itself. We can provide certain interventions, but we are educators. And if we understand that we're educators, that means we're taking a very proactive stance and making sure that we can provide information that may help people stay alive and do well. And in that, we need to understand what are the things that we can do that are going to be minimally invasive, that are going to cause minimum amounts of harm, and that are very, very sustainable. So that's one of the first things. But anytime I have a patient, I first like to identify who is this person, not as a medical problem, but who are they as an individual? Because I have to meet them where they're at. If I'm not meeting them where they're at, I'm expecting them to be something that they're not. That's where we run into a lot of problems and frustrations, because we may have somebody who's 30 years old, and in our minds, we're thinking, oh, this person is going to be exactly like we were when we were 30 years old, exactly like my best friend who was 30 at that particular time. And this person may not. They may have had a series of adverse childhood experiences, which has completely altered their perception of their themselves as well as their physical environment. So we have to understand who people are, what they bring to the table, what is their comprehension of an insight into who they are and what they're going through. And then we have the next steps. After that, we got to figure out what is the problem that that person is experiencing. In the ER, a lot of the stuff we're doing is very, very goal directed, and we're not a primary care facility. We are, but we're not. But we got to meet people where they are. We have to determine what's the physical problem, what's the mental problem that they have, and then based on what that problem is, we've got to figure out what do that person actually need to stay alive. So in the ER, we're always thinking what they call primary survey and secondary survey. Your primary survey is your airway, breathing, and circulation, disability and exposure. If you're ABCDE, technically, if that's not in place, if somebody's not breathing properly, there's no adequate circulation, that person is going to die in a very short period of time. So we've got to focus on what's required for survivability. Then the next step is what do we need to keep, what do we need available? And that's with the patient's input, what do we need available so they can actually do well? And so you're kind of going down this list of all the things that they require for just basic survival on top of the medical problems that they're experiencing. And that's how you start developing a treatment program. The other thing, and this is, I can't stress this enough, is that there has to be levels of compassion that we have with our patients and their family members to the point that we're not fearful of them. I know that's easier said than done, but when you wind up when you're fearful of the people that you work with, when you're fearful of the members of the community, and maybe because you're not from them or because you view yourself as being different from them, you automatically develop this adversarial relationship. And that creates a lot of tension. And those people who are on the other end don't necessarily feel like you're in it best. You're not focusing on their overall well-being because you're stuck in survival mode because you're automatically fearful, and that's when the heads start butting. So there has to be levels of compassion where we understand who our patients are, and we recognize that they've gone through a particular deal of amount of suffering, and that may have impacted their current condition. But because they've gone through those things, you don't necessarily have to take it on and say, "I feel everything." Because no, that can actually be disruptive to our own well-being. But we have to recognize and acknowledge, and maybe help people acknowledge what they've experienced and say, "You went through something very horrible. I can tell that you're uncomfortable. Let's come up with a plan that we think may help you be well." And I tell people all the time, I'm glad you're here. I thank them for coming. I say, I don't want to see you here all the time. And when you come back, I want to make sure you just come back to say hi. So we've got to figure out a program so we can get you, keep you alive and keep you as free from harm as much as possible, so that when you come back and see us, it's only for wellness checkups.
Yeah.
And that's my basic protocol, even in the emergency department. We've carried that over into the same space. Violence intervention is no different than we're treating somebody with asthma. You're just talking about specific diseases, but our patients who die from asthma because they don't have proper treatment are almost the same exact people who are coming in with violent injuries. They're almost the same people who are coming in with these new diagnoses of HIV, who are coming in with undiagnosed, untreated renal or kidney issues, the same people who have uncontrolled hypertension, the same people who are coming in with a lot of these endocrine problems. These are the same people, the same hospital, the same community, the same family members. And so we've got to figure out what does this whole wellness space look like and work from there, as opposed to working from a pathologic point of view.
That's right. And it really does bring up this whole idea that, and with my training of physicians at one of the medical schools where I work, uh, the idea of teaching them about community health, community service, community health, health and human behavior, looking at lifestyles, being able to work in a public health space as far as being able to help people change lifestyles. but we're really talking about here changing the lifestyles and giving opportunities and looking at the trauma that young Black and Latino males are going through every day. What has been the orientation at this point for you as a leader in the medical field with convincing your colleagues that their work isn't just in the hospital, it isn't just in the emergency room, but it also has to be in the community, working as you do with CUNY BMI, early education, early intervention of young Black males and others?
Excellent questions. Let me see if I can answer that a little bit more swiftly. One, I think, is just establishing what is this basic definition of trauma. And trauma itself is any kind of injury that occurs between living tissue. But it's also a physical process. It's also a mental process. So figuring out that's what trauma actually is. On top of that is determining, okay, there are many different types of trauma, and with that, depending on the nature of that trauma, there can be many consequences. And so we have to look at what the trauma is, what the cause of that trauma is, and that should ring a bell in our heads of saying, okay, I have to understand that somebody who's coming in after a trauma that was accidental may be very different when somebody who's coming in after experiencing a trauma where there was an intentional act, which is actually what violence is. Violence is an intentional act of trauma that's been designed to hurt, injure, or kill the person that's on the receiving end. So those are some of the basic definitions. On top of that, just taking it up another notch, ensuring that we have what's called, there's a sociologist from Norway. His name was Johan Galtung, and he talked about violence almost in these three kind of, I don't want to say stages, but violence itself almost being like an iceberg, where you have direct violence, or what we now may call a lot of stuff that we see with interpersonal violence, and that's where you have a particular player who's causing the trauma. So if you've been hurt, if you've been stabbed, if you've been beaten, if you've been yelled at, you know that there's a person or a group of people that are causing that. That's the direct violence. But there are two other components. You've got the cultural violence that's occurring because this is maybe the response of the community as it relates to somebody who may be experiencing certain things. And maybe, oh, we don't like people because of their sexual orientation. Because we don't like their sexual orientation, we're going to make life a living hell because we say we don't agree with them. We don't like that particular ethnicity. And because historically, in the culture of our community, we're going to treat that individual with a certain level or not level of respect. And that itself is technically violence. When you call it violent, when you say, oh, this is just some sort of disparity, people kind of have a little bit of a kumbaya approach. When you say this is actual violence, it's a little bit more jarring because the cultural violence contributes to the direct violence in many ways. And last but not least, you have the overall structural violence, and those are the things and the causes and the systems that contribute to why violent behavior, why direct violence is something that's even occurring. With structural violence, you don't have somebody who's necessarily a player, but if you have people who don't have adequate housing, that's a structural form of discrimination that impacts whether or not somebody does well enough. If somebody doesn't,
racism, correct?
yeah, institutional racism, structural racism. This is all formed under structural violence. When the job market has completely shut down in somebody's neighborhood, and because of that, people can't take care of themselves or their families, so they've got to figure out ways to engage in illicit form of economic development within their respective communities. That is a form of structural violence, and so we've got to understand that there are multiple things that come into play that we need to address. And if we don't recognize who these players are, we're going to provide these band-aid approaches to people.
But more specifically, Dr. Gore, how do physicians, we know social workers, psychologists, sociologists are doing this work, but we know that we are expanding the way that we are educating our physicians. How do physicians get into the community to educate people around this schema as to how and why violence takes place and disproportionately affects young Black male and Puerto Rican males?
So as far as getting into the community, the first thing is we have to understand we're not getting into the community. This is our community itself, as opposed to looking at it as an us versus them. When you realize, so I live in Bedford Stuyvesant. Brooklyn, and I grew up in Flatbush, and I grew up in pre-gentrified Fort Greene. And so when I'm speaking to people about violence itself, I started when we launched our organization, CAVI, which is our hospital, school, and community-based violence intervention program. A lot of the people we were talking to when it first started, people who lived on my block. These are the people who were my patients who also lived in the neighborhood. So we started off with those basic conversations. Dr. Selby can probably attest to this. I'm sure you can attest to this because people already see that you become a resource for information. They're going to send their other friends and family members to you to talk to. I need you to talk to my son about some stuff that's going on. Be like, I don't know what it is. I don't know any other doctors. You're the only one. I see you all the time. I see you on your skateboard. I see you in the supermarket. Somebody told me that you were a doctor. I didn't even know that that's what you did because you don't look like you're supposed to be a doctor. But because you're the closest person I have and you live in my neighborhood, you're an accessible person. So I think a lot of us, we have to realize, one, it can't be us versus them. This has to be looking at, I'm engaging with the members of my respective community and making sure that you're accessible. I'm not saying being accessible 24/7, but accessible in the sense that people are understanding what the information that you're telling them. You're making that information very palatable, but you're also seeing them who they are. When people in the neighborhood come and talk to me, I'm not like, oh, get away from me. Hey, how you doing, brother? What's your name? Sister, what's your name? Oh, good. My name is Rob Gore. I don't even introduce myself as doctor unless we're in like the hospital setting. But I want to make sure that they know that doctor is my title. This is what I do for a living. But I'm also a member here in this community. Yes, we may have had some different life circumstances, and even may have some differences in terms of what our what our economic access is. But I want to make sure that I can take off as much as possible to the point that you can actually see me and I can see you, and we're both vulnerable in this space itself. That's how that conversation begins. And it's also asking them, how can I be of help to you? A lot of times, we've all been guilty of it. We're like, look, this is what's wrong with you, da, 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 and take this and then come back in 2 days. But we haven't heard the person. We need to take, and that listening part that Dr. Selby had spoken about before, what I think you as a mental health practitioner probably does better than any of us is being able to sit and listen. And doing so with the sense that somebody may tell you something when you're listening, and it might be exceptionally uncomfortable and dysregulating for you and triggering, but you've got to sit there. It's almost a meditation in itself, but it's like, in order for us to solve this problem together, I need to understand who you are, what the circumstances you bring together, and what are the different challenges, and what are also your gifts so that we can solve this problem together. And I think that's another essential thing. What are the positive things that you have? What are the gifts that you already have naturally that you've been doing historically that can help us solve this problem together? So this is a very synergistic approach to helping make sure that you're well.
Right, and this is something that we call more of a liberation psychology, being able to break all the boundaries or all the gates that keep them from realizing who they are. Dr. Selby, welcome back, of course. Your organization, the organization that you're director of, again called Muse, Mentoring Underrepresented Students in Emergency Medicine. What kind of training are you? These, I assume, these are medical students, correct?
That is correct. Yeah. Thank you guys for your patience with
Oh, absolutely,
technical difficulties, but I'm
absolutely. And we saw that
glad to be
lovely
back.
little one who was to your stage right there. Just love.
Yes.
That's our tomorrow, right? That's our potential. But with your students in emergency medicine, what are some of the things that you are relating to them about seeing their patients coming through the emergency room as being more than just victims of violence, victims of poverty, whatever the case is, but about being whole individuals where you meet them as Dr. Gore said, and I believe you said, meeting them where they are.
Yes. Well, one of the things that we definitely try to impart to our students, both in Muse, the mentoring presented students in emergency medicine program, but really also to all of our medical students, all of our trainees, right? Because we have other advanced practice providers like PA students, nurse practitioner student, all of the students. But essentially, one of the things that we really try hard is that, right, this day and age in the 21st century, right? We talk about the practice of medicine. We are moving towards a more collaborative model of practice, right? When it comes to our patient care that we're delivering at the bedside. Used to be of a more paternalistic model. That's what Dr. Gore was referring to, and like, hey, take 2 aspirin and call me right tomorrow morning, or these are the orders you are going to follow. There's no discussion of your options as far as diagnostic plans or treatment plans. Now it is a more collaborative relationship, right? Where you come in with a particular concern or a complaint. I'm going to talk to you about that. And then we're going to figure out the best diagnostic and treatment plan that is in accordance with your beliefs, your values as a patient, right? Do you want a blood transfusion, right? I think you need this blood transfusion for these reasons, but in observance of your religious beliefs, right? If you're just Jehovah's Witness or whatever other sort of belief systems that you have, that has to be taken into account, right? Because we might be doing more harm in that regard than good, right? From a or medical standpoint, we have obvious, and Dr. Gore kind of talked about this, right? Obvious goals that we're sort of set upon. You want your hemoglobin or your blood count to 7. But guess what? If that is going to bring you duress psychologically, if that is going to ostracize you in your community, right? Yeah, you're alive and you're able to go back into your community, but how you go about navigating your environment, if you're going to be under psychological distress, we might have done more harm to you than good, right? And that is something that we try to, as an example, but that's something that, one of the things we try to really get across to our students is that, hey, we need to, in addition to focusing on these medical complaints, right? I know you can make a diagnosis. I know you can, come up with a diagnostic and treatment plan. But I need you to really this patient and collaborate with this patient to optimize their outcome, whatever it be, right? And it takes a little bit more, believe it or not, because that is the challenge, right? That we think all of the medicine stuff and focusing on the physiology, pharmacology is the challenging part, but really building a relationship with your patient that will allow them and empower them to make better decisions, better, more informed regarding their care. That is the bigger challenge.
All right. Dr. Gore, if you will, I know that we are talking about, and we are wrapping up, we're talking about the critical challenges, psychological, physiological, wellness, survival. As a Black male and a physician, if you would, what is the message that you have for our young Latino and Black male people in this country as to how they can enhance those aspects of their lives so they can be holistically healthier? And then, Dr. Selby, of course, I'll go to you with the same question.
Excellent question. I think the first thing is to acknowledge that one, yes, we may have a challenge that we're dealing with, but we do have a capacity to get better and to heal. If you don't think that you're going to heal, if you don't think that things are going to improve and get better, and I think a lot of that just depends on perception, but if you don't believe that in your whole heart, it's not going to get any better. So that's the first thing. In order to do so, we recognize what's required for us to do well. We can have accessibility to medical care and medications and even behavioral health services, but we underestimate the power of community and understanding what our community is, who is our list of helpful people within that community, who is our support system, is a very essential thing in order to actually be well. And last but not least, what is our physical practice that we can engage in? Mental health is directly tied to physical health, which is tied to what we are able to eat and ingest. But now again, there's different ways to take this, but I think we need to make sure that our bodies continuously move and that we train and that we have some sort of physical practice.
Yes.
That could be yoga, that could be running, it could be lifting weights. For some people, it might just be walking.
Right.
Basketball. I do jujitsu and Brazilian jiu-jitsu, and I do judo because those are things that my body requires. I do meditation every day, whether I want to do it or not, but that's what's required in order to kind of regulate my nervous system so that I'm able to tackle more comprehensive problems and be more present. A lot of PTSD, acute stress disorder, These are conditions and challenges that members of our community experience because we're living in time dimensions that are other than where we are right now. We are focusing on things either in the past or in the future that haven't occurred yet, but we can't get beyond that. And that kind of comes back to what many people in different meditative spaces talk about, and that's being present and being mindful. So that physical practice helps regulate our systems that allows us to be a lot more present so that we can tackle these problems that we've been experiencing a lot more coherently and efficiently.
And Dr. Selby, what has worked for you that you can share with our young Black and Latino males? I mean, look at how both you and Dr. Gore have climbed to the top, but it wasn't easy. You earned all of that and had maybe some of those very same stressors as I know I did coming up as a young Black male.
One of the things that I really try to um, share with my mentees, students, even is that right individuals that are invested in your growth and development. I can point to Dr. Gore, right, on his program, mentors that I've had in the Black Male Initiative at Q, that when I told them about my interests, passions, even, um, especially when we talk about in medicine, they took me up on that. And so when I talk about the number of mentors in my life, and these are not always individuals that have to be right in alignment with or having expertise whatever your objective or goal is, right? So one of my biggest supporters and mentors, she was like a surrogate mother to me, was Miss Gloria Thomas. She was one of the administrative assistants at the City College of New York in the what we call the IRADAC, Institute for Research on the African Diaspora in the Caribbean. It's a long name, but she was an administrative assistant right there. Didn't have any responsibility for me or guiding me, mentoring me whatsoever. But when I told her I wanted to be a doctor, took me across, pointed me in the direction of Jerry Guyton, molecular biologist on campus, also the director of the research centers and minority institutions at the time. She said, you need to know this person. You need to develop a relationship with him. Get into the lab, do what you have to do, because they will get you on the path to success in applying to medical school. Right. Ended up in being Dr. Guyton's lab, met Dr. Michael Sams, another mentor that hearing what I wanted to do. Hey, these are the things you need to do. We got to get these research projects for you, get you published, build your CV. And again, this is right over and over again. When I talked about, hey, this is what I want to do, there are people in this world that will nurture you, right? That will support you, that will give you information, that will help you and grow and develop not only professionally, but personally, and that are dedicated to that. Dr. Rob Gore is dedicated to that, right? I still call this man to this day, talking about challenges with professional stuff. He knows my family, the things I go through with my girls. I got two girls, 8 and that's the biggest challenge of my life, man, raising these soon to be young ladies, right? But I have a mentor that'll help me through that challenge. When I have questions about, just sort of being in this profession in medicine and academic and at that, right? How to get promoted. I have a list of mentors at Emory that if I went through, you'd be astonished, right? How much support. There's one of these new concepts actually that I've seen really floating around. Actually brought to my attention by Dr. Lynn Holden, the founder and CEO.
Holden,
Yep, mentor in medicine. She said you need to have your own board of directors, right? Just as a corporation has its board of basically this group of individuals, right, that will give you the guidance and support that you need to grow and develop, whatever it may be. You want to be a police officer, there are individuals in your community or that you can get in contact with that will help you develop in that domain. And sometimes it takes a little work to find out who those individuals are, reaching out, cold calling, emailing. I've definitely done that and made some connections, but there are people in this world that will take you under their wing, that will grow and develop you. Yes.
Thank you very much, Dr. Selby, for sharing that. And I guess the bottom line is, Dr. Gore and Dr. Selby, what you're saying is that there are resources that are out there. It's about the mentorship. We have to step up as Latino and Black males as far as being mentors and role models, but we need our young men and women to be able to step up and also be able to grab onto the resources that we put out there. We do have an extra responsibility and a higher authority to answer to. That's about all the time we have, but I really want to thank you once again, Dr. Maurice Selby, Assistant Professor, Director of Emory Muse over at Emory University School of Medicine. Thank you so much for sharing your insights. And as well, Dr. Robert Gore, attending physician, emergency medicine, Kings County Hospital, and the author of the best-selling book, Treating Violence, an emergency room doctor takes on a deadly American epidemic. And with that being said, thank you all for joining us, and I will hand it back over to Jorge Alguera.
Thank you so much, Dr. Gardier. Thank you so much, Dr. Gore and Dr. Selby. I'm in the background just taking notes, and I truly appreciate everything that you've said, because, you know, in higher education, we deal and we understand that a lot of the issues that our students have in attaining their academic goals have to do with mental and physical health. So I truly appreciate your insight. Thank you all so much. We will put into the notes of this podcast or of this video a lot of the resources that all the doctors shared today. And we look forward to sharing with you all once again. Please stay warm wherever you might be, and be sure to take care of yourself. Thank you all so much.